Bismillah ar-Rahman ar-Rahim. Thank you for joining us. I'm Dr. Abdul Qawi Mansari, consultant endocrinologist, and in the next 5 minutes I will talk about basal bolus insulin combination or IDGASBART, and I will talk in initiation in particular. First of all, let's see some patient here. First of all, let's see a patient scenario. 45-year-old male, type 2 diabetic, currently on multiple oral medications, metformin, DPP-4 inhibitor, glimepiride, SGLT2, and hemoglobin A1C is 9.5, which is of course uncontrolled. Okay, what can you do in this patient? Of course, we need to add injectable therapy, and let's assume that we will add insulin. The question, what is really better in adjusting and getting into the target very quick? Is it basal insulin alone or basal bolus combination? In this study, which is in insulin naive type 2 diabetic patients, both Japan, 296 patients were divided into two groups and followed up for 26 weeks. You can see the two groups, either IDGASBART or Rhizodec plus oral hypoglycemic, or glargine 100 once a day plus oral hypoglycemic. The patients were of course uncontrolled. The starting dose was 10 units a day, and it was increased every 3 days to reach the target. As you can see here, and you can expect of course, because we are using 2 insulin in 1 pen, the reduction of hemoglobin A1C will be more in a Rhizodec case compared to glargine case. Okay, now confirmed hypoglycemia was much less, and nocturnal confirmed hypoglycemia was much less, but in both they were not significant. So the hypoglycemia confirmed and nocturnal hypoglycemia were less in IDGASBART or Rhizodec compared to glargine, and this was not statistically significant. Also, the people who reach, or the patients who reached hemoglobin A1C less than 7, and the patients who reach hemoglobin A1C less than 7 without hypoglycemia were higher in IDGASBART compared to glargine, and this is again expected of course, because you are using 2 medications in 1 pen. So in summary, after 26 weeks, hemoglobin A1C was better in IDGASBART. The total daily insulin was similar in both cases. Confirmed hypoglycemia and nocturnal confirmed hypoglycemia were lower in IDGASBART compared to glargine 100. So let's go back to our case. We have this 45-year-old male, type 2 diabetes, already on these medications, and hemoglobin A1C 9.5. So we will start Rhizodec in this case. Okay, so what is the starting dose? We can start 10 units once a day or 6 units twice a day. If the patient is taking 1 big meal, it will be once a day. Of course, if 2 big meals, it will be twice a day. And then we adjust according to the fasting blood glucose. The fasting blood glucose target usually between 90 to 120. If it's less than 90, we will decrease by 2 units. If it's over 120, we will increase by 2 units after 3 days. But we need to remember, of course, we need to adjust this target according to the patient. If there is elderly, it will be like 100 to 150, and according to the patient. Now, this is what we give usually the patient. We will ask him to start. In this patient, we started 16 units because you can see the fasting is very high. The 2-hour postprandial is very high. So we started 16 units a day, but we told the patients his target in the morning will be between 90 to 120. He can decrease if it's less than 90, or increase every 3 days by 2 units if it's over 120. The patient did that, and after 3 days increased to 18, and then after 3 other days increased to 22, and you can see the fasting blood glucose went down from 250 to 187, and the patient kept increasing. He reached after 4 months to 26 units before the main meal. And when we say the main meal here, because it's very flexible, you can change the meal every day. You can take it today and with the breakfast, tomorrow with the lunch, after tomorrow with dinner, it's okay. Anyway, for this patient, he reached 26 units before the main meal, and the fasting were as 80, 110, 117, which is really very good, of course, without hypoglycemia, and hemoglobin A1C went down from 9.5 to 6%, which is really excellent. The other case reached to 30, and this is where if the fasting blood glucose is less than 90, the patient needs to decrease by 2 units, but this was not the case. So the patient was re-educated about decreasing the dose of insulin if there is hypoglycemia. And thank you very much.